Good afternoon, and welcome to Westwood, California, and the UCLA Medical Center campus here at the Ronald Reagan UCLA Medical Center. I'd like to thank you for joining us here for this webinar that we're streaming live through YouTube and through Facebook Live and through UCLA Health on the UCLA Health webpage. I personally want to thank Ashley, Georgiana, Mark, and Cleve for getting this on. Their hard work behind the scenes really, this wouldn't be possible without them, and so I want to thank them for doing this. My name is Isaac Yang, and I'm an associate professor in neurosurgery in the Department of Radiation Oncology, and I'm here to talk about superior semicircular canal dehiscence syndrome, and specifically, I'm here to answer one or two questions specifically about the minimally invasive keyhole middle fossa craniotomy approach. I want to thank everyone for joining. I know our last YouTube webinar got over 16,000 views on YouTube, and for today's Facebook Live and YouTube stream, there's over 100 people registered to be watching this live, and this makes this one of the most registered webinars that UCLA Health has ever done. You can join us now live as well through Twitter at UCLA Health and hashtag UCLAMDchat. If you tag us through Twitter, we have people here who are looking for these Twitters and these hashtags through hashtag UCLAMDchat to see for questions to make this live and interactive. To give you a brief recap of the SSCD, or Superior Semicircular Canal Dehiscence, and if you want more specifics, I ask you to go look at the previous YouTube webinar that we did on SSCD. That has a lot more of the basics. And you can also look at a live tweet. We did a live tweet of an SSCD surgery, and that was done live, and that's also online at UCLA Health. You can see a live tweet of an actual SSCD surgery. But to give you a quick recap, this is a rare disease that was only given a name about 20 years ago. In 1998, it was described by Dr. Miner, and he's now a dean at Stanford University. And since before that time, this disease had no name, and so it's a young disease, it's a rare disease, and not a lot is known about it. The basics are, for the common symptoms, you hear your own heartbeat, you hear your own voice. Sometimes you can hear your eyeballs move, your neck muscles move, you can hear your own footsteps, and where common sounds or quiet sounds can cause vertigo and dizziness. For treating SSCD, there are three major approaches: the round window approach, the transmastoid approach, which is abbreviated as TM, and the middle fossa craniotomy, the MFC. And I'm not here to argue the pros and cons of each different kind. I'm only here to talk about the middle fossa craniotomy. That's the approach we recommend here at UCLA, and that's also the approach that was recommended. I saw a different webinar by a different institution, Johns Hopkins, which is also one of the top hospitals in the country. And I was watching a webinar by them and a video by them, and they recommended a middle fossa craniotomy as well for superior semicircular canal dehiscence. So for SSCD, they recommend that as well. Here at UCLA, for SSCD, we recommend MFC as the preferred approach, but it's not for everybody. And if you can't get that done, you may need a transmastoid approach. And so that for each individual person, everyone's anatomy is different. Even though it's one disease and it's SSCD, everyone's SSCD needs to be approached uniquely, and so you'll have different approaches. But the most common approach, and the approach we recommend here at UCLA, is the middle fossa craniotomy. And so this is what SSCD is. This is from a publication a few years back. You can see here this arrow is pointing to the top of the arcuate eminence. The arcuate eminence is usually this bony covering of the SSCD, and here that bone of the arcuate eminence has eroded, and there's a hole from the superior semicircular canal into the brain space. So there's a connection between the brain and the inner ear, between the brain space, the intracranial vault, and the inner ear, and this hole is what we attribute to these symptoms: hearing your own voice, hearing your heartbeat, hearing your eyeballs, neck muscles move, and contributing to having difficulty thinking, having problems with balance. And so this is superior semicircular canal. And the middle fossa craniotomy is an approach where you make a hole here in the bone, in the skull. You come along the bottom of the middle fossa, and you gently lift up the covering of the brain. You don't actually lift up the brain itself. You lift up the covering of the brain, which moves the brain as well. You come down to this hole, and you fix that hole. And if you fix that hole, there's a very high chance that people's symptoms get better, that there's an improvement in the symptoms. Now, these are all pictures that we've put blockages on so that you can see that just the incision. This is a traditional middle fossa craniotomy. This is a classical approach, and this is a SSCD repair that that was done at an outside facility by another surgeon. And so another surgeon at another hospital did a middle fossa craniotomy. This is the incision, and they came here for a revision. So because it was a revision, when we have to do revisions, we basically are forced to use the exact same incision that they used before. And so this is a surgery that we did as a revision, and this is the classical approach. And because someone else had already done the traditional classical middle fossa craniotomy, we were forced to use the exact same incision. And so you can see here's the ear. It goes up, goes behind the ear, up and around. And other variants I've seen come a linear incision from here all the way to here. There's some version of this, but this is the traditional middle fossa craniotomy approach. I think now more modern and more current series use a mini middle fossa craniotomy. So a mini MFC. Here's the ear. You can see the incision goes up, over, and down. And this is really the incision that we here at UCLA were using between about 2011 and about halfway through 2014. We were using this mini middle fossa craniotomy, a mini approach. And this is much smaller compared to the previous incision. You can see a previous scar. We were shrinking the incision down already through a mini middle fossa craniotomy. Now, one of the very most common questions I get is how in the world does a keyhole craniotomy differ from an endoscopic craniotomy? And this is a paper from the Laryngoscope published in 2014. This is from Harvard, one of the other really great centers for SSCD approach. And this talks about one of the published papers on endoscopic assisted SSCD repair. And when you look at this paper, and this is straight out of that paper, they describe a mini craniotomy. So they do a mini middle fossa craniotomy, and that this craniotomy is about 3 by 2 centimeters. And I agree with that. So that a mini craniotomy is about 3 by 2 centimeters. That's how big the bone flap has to be in order to use an endoscope. And so this is us here at UCLA. This is my partner, Dr. Quentin Gopin, who's a world expert otologist, head and neck ENT surgeon, and really one of the world's experts in SSCD. And here we're using an endoscope. You can see the endoscope being put in for an endoscope-assisted SSCD repair. And so even in endoscopic-assisted SSCD repair, you're going to have to do a mini middle fossa craniotomy. And this is what the incision looks like. Here's the ear. Here's the root of the zygoma underneath, and this is that line. We don't make that incision. The incision starts here, goes up, over, across, and down. And we pull this down, and in this space, we fit 1 to 2 centimeters by 1, 2, 3 centimeters. So in this space, a 2 by 3 centimeter craniotomy has to be done. And that's really the same craniotomy we were using between 2011 and 2014 was a mini craniotomy. And then you can use an endoscope to use it or not use it. Well, here's what's happened, and here's what's changed. This is what we've developed at UCLA, is the mini keyhole craniotomy. And this, we're really fortunate to have. This is from Surgical Theater. This is the company that helps us do 3D reconstructions. We use this in the OR. This is one of our patients that had the old craniotomy. You can see this, they had the old mini middle fossa craniotomy done here. They had this done on their right side. And they came to us between 2011 and 2014. Well, they had bilateral SSCD, and they came to us after 2014, and they had the mini craniotomy done on this side. And so you can see the size of the bone difference. This is approximately 2 by 3 centimeters. This is the mini MFC, the mini middle fossa craniotomy. We did not use an endoscope on this first approach, but this is the way we did it before 2014, a mini middle fossa craniotomy. And now the hole is the size of a dime. It's about 1.6, 1.7 centimeters. And if you go onto Wikipedia and look at the diameter of a US 10-cent dime, it's about 1.7 centimeters. And so 1.7 centimeters is about how big our craniotomy has to be, about 16 or 17 millimeters. And so through this tiny hole, and if you look at this hole is about at least about a quarter. It's about 75% smaller than the overall surface area of this. You can see that this is the old surface area, and if you took this, it would roughly be about a quarter of its old size. And so we are doing this through a hole in the skull that's about 75% smaller than it used to be. And so it's very, very small in its invasive, making a hole in the bone. And we do this through an incision that's approximately 1 inch. And so that patient, she has this scar on one side, which is this scar on this side. And on the other side, she's got this scar, which is for this opening. And so the scar also gets smaller because our incision is able to be smaller, because our incision is approximately 1 inch. And so we were able to do this smaller. Well, how do we do this? Well, there's a lot of technology that's involved in this. In order for us to be able to find the superior canal dehiscence through a smaller hole, we need to be extremely precise. And being precise allows us to make the hole smaller. It allows us to make the craniotomy, the craniectomy, the middle fossa craniectomy smaller. And by making that smaller, we can make the incision smaller. And so what we do is for all of our cases, we use surgical theater to do 3D reconstructions. And so here, this is my partner, Dr. Quentin Gopin, and he's looking here at the head. And what we get to do is we get to change the size of the hole. Using a 3D reconstruction, using a mouse pointer, you can change the size of the hole. And so we make the hole as small as possible so that we can see exactly where we need to go. The next step is that we use virtual reality. And this is using a Oculus Rift headset. We've also used HTC Vive. Using a virtual reality headset, this is my partner, Dr. Quentin Gopin, who has the Oculus Rift headset on. We can look into the 3D reconstruction as if we're doing virtual reality. And so this isn't a model. This is the actual patient. This is your actual head CT, your actual MRI, reconstructed as an actual replication of every patient's specific individual SSCD. Because everyone's SSCD actually is a little bit different. Some people have larger holes, some people have small holes. Some people, their hole actually looks like 2 separate holes. And so based on your individual anatomy, we do specific 3D reconstruction, and then we can do it in virtual reality. And this allows me and Dr. Gopin essentially to look inside your head before we look inside your head. This allows us to do the surgery before the surgery. This allows us to rehearse, to practice, not just in our minds, but now in 3 dimensions, like a video game, to do the surgery in virtual reality before we do the surgery in real life. And so this is what it looks like. And this is my best replication, is that I can't give you a headset at home to do the 3D reconstruction. So we've done this through surgical theater and UCLA neurosurgery to give us what this reconstruction is like in 3 dimensions. And so here you can see the root of the zygoma. Here's our dime-sized hole. And as you go through the dime-sized hole, here is the SSCD. We've put this marker so that if you don't know bone anatomy and you can't see it very well, what spot we're looking at. This is the superior canal. You see that? And so we are looking right here again at the superior canal dehiscence from multiple angles using 3D virtual reality. And when you put this headset on, you can see this and zoom through it and fly through it and rehearse the surgery. And so this allows us to know exactly how small we can make the hole so we can be very precise in heading for the SSCD. The other technology that's very important is Neuro Navigation. Here you can see that we use Brainlab Neuro Navigation. There are several companies that I know of that make Neuro Navigation. There's Medtronic, there's Stryker, there's Brainlab, all these off the top of my head. But the one that we use here at UCLA is Brainlab Navigation. And we find that this Brainlab Navigation allows us to precisely register so that we can use a wand and have real-time navigation. So that not just in virtual reality, but in real space, we know exactly where we are in relation to the CT scan, because that allows us to know where the superior canal dehiscence is. That allows us to know that when we make our small opening, although we rehearsed it in virtual reality, we rehearsed it in our mind, when we look for the superior semicircular canal, we know where it is in real time by using Neuro Navigation. And so these are infrared sensors that detect where this arc is that's attached to the head. This is the screen that reflects where we are in real time. And down here in the Brainlab computer is a supercomputer that does high-powered, high calculation, precise navigation that does 3D reconstruction quickly and allows us to recognize where we are in real-time space with the BrainLab wand as we do reconstruction. And what we have here at UCLA, since we work with BrainLab and surgical theater, is that the two machines and two computers are actually connected to each other. And so we do BrainLab navigation. We also bring in the 3D reconstruction virtual reality, and we can see our wand in 3D recon. We don't put the headset on during surgery. But what we can see is on a computer screen, just like you saw there, where we are in 3D space, in addition to the BrainLab reconstruction that we do for navigation. And so we do these middle fossa craniotomies, and I apologize if the picture is a little bit graphic here, but this is the surgery. This is the picture of the minimally invasive keyhole MFC. And so this looks large, but this is really blown up. This is approximately a 1-inch incision. This here is the root of the zygoma, and this here is the external auditory canal. And one of the things that allows us to do a minimally invasive keyhole craniotomy is experience. We've done so many of these now, we know exactly where to go and how to make that hole small so that you can go down there and find the superior canal dehiscence. This has actually been submitted to the Journal of Neurosurgery, and it's been accepted for a publication later to be coming out. And what we want to do is help teach and help advise. We are teaching our current fellows, our residents, medical students on where to make the best opening to do this keyhole craniotomy. And so here you can see these two purple lines. These purple lines don't really exist. You don't open up someone's skull or someone's up head and you don't see these purple lines. We've put these purple lines there. And if you draw a line that's parallel with the root of the zygoma, we call this the line of Yang. If you draw another line that's perpendicular to the external auditory canal, so here's the anterior, the posterior auditory canal, and here's the external auditory canal. If you draw a line that's right down the middle of it, that's perpendicular to the external auditory canal, we call that the line of Gopin. And when you draw a line between the line of Gopin and the line of Yang, that intersection point is where you go down. That is where the dime-sized hole has to be. The dime-sized hole is made here at the intersection of the line of Gopin and the line of Yang. And if you make a dime-sized hole there and you go down about 2 or 3 centimeters in just about every patient, you're going to be within 80 to 90% close to the SSCD. Without navigation, just in any patient, that's going to get you close. And then you use the virtual reality, you use a 3D reconstruction, use the Neuro Navigation, and you're going to go from 80 to 90% down to 100%. You're going to find exactly where this tiny hole is. Because the superior semicircular canal dehiscence, this hole is about 2 millimeters. It's a super, super small hole. It's about the tip of a ballpoint pen. It's the needle in the haystack. And so experience, technology, and navigation help us to get down there quickly and effectively. And so this is the picture here. You can see here, this is the line of Yang. This is the line of Gopin. Here's the intersection point. We've made our mini keyhole middle fossa craniectomy, and this is a ruler to show that this is approximately 1.5 centimeters. You can see the dura underneath there. It's perfectly intact and pristine. This is the hole we make in the skull. This is as much of a hole as we make. This is all we need. And the experience and the magic and the expertise of Dr. Gopin and our team here and the technology we've used allow us to see everything we need to see. Because if we're making our hole smaller and we don't see what we need to see, and we don't make the repair, and we don't make people better, well then a small hole, it's of no use. But if we can make our hole 75% smaller and do everything through this dime-sized hole and see everything that we need to see and fix everything we need to fix and still make people better, well then shucks, this is the better way. This mini middle fossa craniectomy, keyhole craniectomy, is faster, it's safer, it's more effective, and it's just as good, just as effective, and just as efficient at making people better with SSCD. And so this is all we do through this tiny hole. And so this is what we do through our experience. This is me scrubbing in here for surgery. And another question I get very often is, how many SSCDs have we done? How many SSCDs repairs that we do? Well, I want to answer those questions is, I don't know how many we've done in total, but I do know that last year in 2015, we did 48 of these SSCD repairs, 48 last year. And so I guess if you divide that by 12 months, we average about 4 a month. And so that makes UCLA and Dr. Gopin and myself one of the most experienced centers in the country, and definitely west of the Mississippi. And that we're one of the only centers who are publishing and developing this unique, novel way to treat SSCD. This is a very unique way that we developed here at UCLA, that we don't know of anyone else doing, and that we've developed this. We're publishing this series. It's a large series that to be reported, and that this novel keyhole SSCD repair through this mini keyhole middle fossa craniotomy, this is one of our ways to do this. And so if you go get a middle fossa craniotomy, I believe you're going to get better. But our signature surgery here at UCLA for SSCD repair is this mini keyhole middle fossa craniotomy. And so this is the mini middle fossa craniectomy. After the repair is done, you can see there's some glue in this space. I apologize for the surgery pictures. I know that's not fun to see at lunchtime, but this is the surgery here after repair. And again, we're just putting the rulers down so that you can see. It's really hard to tell how big these things are, especially if you're not in surgery and you don't have a frame of reference. So we put this ruler down, and here's the 0. Here's the 1.5, it's a little bit past it. This is about a 1.6 centimeter mini middle fossa keyhole craniotomy. This is a minimally invasive craniectomy. It's keyhole, and a dime is if you put a dime here, a dime diameter would be 1.7 centimeters. That's an American 10-cent piece. And so the mini middle fossa craniectomy, this keyhole craniectomy, is extremely small, and I don't think it can get smaller than this. One of the other benefits of this is that this minimally invasive keyhole craniectomy, and this is courtesy of my partner, Dr. Quentin Gopin, is that it shortens our OR time. It shortens our OR time. When we were doing the larger keyhole, the larger mini middle fossa craniotomy, our surgical time was over 2 hours. 2.5 hours, sometimes 3 hours, and these are all the average times. And so we were operating between 2 and 3 hours. Now, our craniotomy time, our average, is about 90 minutes. From the moment that we start to the moment that the last 10 staples, and really, the whole incision is done through 10 or 11 staples. From the moment that we start to the moment the last staple is placed, we average about 90 minutes. Our shortest surgery was 55 minutes, under an hour, when everything goes super smooth. But our average is 90 minutes, so the surgery time is smaller. And so again, this is another picture here showing the same thing. Here, this is the line of Yang and the line of Gopin, the intersection and the craniotomy. We do a smaller MIS, minimally invasive keyhole craniectomy. Our operative time is 90 minutes, and Dr. Gopin and I, we really favor this approach. And the reason why is it can be extended for the regular mini middle fossa craniotomy. Let's just say we do this minimally invasive keyhole middle fossa craniectomy, 1.6 centimeters, and we do this little approach and we can't get down to the SSCD. The anatomy is difficult, things aren't going smoothly, we can't do it through the normal small approach. Well, what we can do then at that point is we can curve the incision around and drill another burr hole and make this larger to the normal mini middle fossa craniotomy. The 2 by 3 centimeter approach, that's still possible through this approach. And so the reason why we favor this approach is that we're going to try to do the MIS keyhole craniectomy every time. We start off with that approach, but our backup plan, if the technology fails, the virtual reality fails, the brain lab navigation fails, the anatomy fails, everything is just going wrong, what we're going to do is we're then going to extend this into the normal mini middle fossa craniotomy, the 2 by 3 centimeter approach. And perhaps at that point, we can bring an endoscope in if we need it as a plan B, plan C. And so there's a backup plan, which is plan B, which is to extend to the mini middle fossa craniotomy. And the backup plan to that is also to use the endoscope, as you saw Dr. Gopin doing for that particular SSCD repair. But we're going to try to start with the minimally invasive keyhole craniectomy, because that takes about 90 minutes. This is also from my partner, Dr. Quentin Gopin, the treatment techniques. And this is his slide, and so he really knows more about the specifics. We do a multidisciplinary approach here at UCLA. I'm a neurosurgeon. I'm a board-certified neurosurgeon at UCLA. Dr. Gopin is a board-certified ENT head and neck otologist. I do the opening, I get him down there safely, he does the repair, and then we come out together. And so we do a plugging versus resurfacing. There's a lot of controversy about which one is better than the other. If you look at PubMed, there's numerous papers that show there are excellent results with both techniques. And just like how we're showing that we use the line of Gopin and the line of Yang, what we're doing here is not secret. It's transparent. We're trying to publish, we're trying to put this out there so that everyone can see what we fix this with. And the repair that we do, we use fascia, we use bone pate, we use bone, a little bit of bone grind. Bone pate is just some of the bone grind that we make and we harvest as we're going in. We use bone wax, and we use some Tisseal, biologic glue, and we use a little bit of helostat. Dr. Gopin is adamantly against using bone cement. Occasionally we're forced to use it, and you have to use it when you do, but he does not like using bone cement in the repair. And so he has a really strong no. This is Dr. Gopin's no for bone cement. We do not use bone cement for SSCD repairs. He strongly does not advise using bone cement. So the mix that we use is a combination of these four. A little bit of fascia, a little bit of your own autologous bone, a little bit of bone wax, and a Tisseal glue and helostat. And these things we use so that it's your own muscle fascia, your own bone that's going in to help you make your own fix. I call this an organic repair of your SSCD. We're using your own temporalis muscle, just a small piece. We're using your own bone. You know when you make that dime-sized hole? We don't throw that bone away. We keep that bone, and we use that bone, we grind it up, and we use that bone to make your own fix. It's the whole foods organic approach to repairing SSCD. Using your own bone, using your own tissue so that nothing gets wasted. So that the bone that was here on the outside at the beginning, we use that to repair your SSCD on the inside. And so this is what the scar looks like once it's healed and the staples are in place. Here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 staples, 1-inch incision, dime-sized hole. This is what it looks like when the staples are in place. This is what it looks like when the staples are removed. Again, it's a very nice cosmetic result. The scar looks very nice and looks very hidden around the ear. And I had just a whole bunch of pictures of these. This is when the staples are just removed. You can see a little bit of scabbing here. But again, those 10 staples come out. It's really hard to even see the scar. And this is what happens when the hairs come out. This is at the 3-month visit. You can see the hair has grown out here to this degree. You can still see the scar here, and the hairs come out. At 3 months, this is what it looks like. It's really hard to see. The scar has been completely hidden. This is in an Asian male. Again, he wears his hair shorter, and so it's not going to grow out as long. But you can see where the staples were, and this is the scar. Here's the ear. And the scar, again, is hard to see. It's hidden really well because our incision gets smaller because our opening is smaller. And so using a minimally invasive dime-sized hole, our incision is approximately 1 inch, and that makes our scar much smaller. And this is what it looks like significantly later after the incision. You can see here, you can still barely see the scar here. You have to pull a lot of the hair out to see it. This is in one of our female patients. The scar is pretty hard to see because the incision is so small. And so this is a picture of me and Dr. Gopin. This is me wearing the virtual reality headset. This is really individualized virtual reality. We aren't just using an atlas or a general picture saying, well, it's kind of here and it's kind of in that direction. What we're doing is individualized surgery. We're focusing our surgery, we're tailoring our surgery to each individual patient. Because some people, their craniectomy can actually be even just a touch smaller. For some people, their craniectomy have to be a touch larger, maybe 1.8, 1.9 centimeters. And so we're doing individualized virtual reality and using the virtual reality technology, using the surgical theater and the brain lab, allowing us to rehearse the surgery before the surgery. To do the surgery before the surgery allows us to individually tailor our middle fossa keyhole MFC craniectomy that's minimally invasive, tailored to each individual patient. And so this personalized individual surgery starts with the 3D reconstructions and the virtual reality. We also have really close collaborations between myself, the neurosurgeons, the ENT surgeons, the otolaryngologists, neurosurgery, facial and plastic surgery. That's this multidisciplinary team allows a group of experienced surgeons to come together and to work together. And that everyone at UCLA should be on this journey